Hello everyone, my name is Jen Nolan and I'm the Programs Manager at Musculoskeletal Australia, and I'd like to warmly welcome you to our webinar this evening on the topic of fibromyalgia. In line with Musculoskeletal Australia's focus on empowering consumers through education and support services, we are offering a series of webinars for a consumer audience during 2019. Our list of webinars should be on your screens now. Now, I know some of you may be watching a webinar for the first time. So if you have any problems during the webinar, please phone the number in the chat box on the left of your screen or type a message in the chat box. My colleague Helen is typing a message in the chat box now. As a backup, everyone will receive a recording of the webinar presentation in the next few days. So if any problem can't be resolved, you'll be able to view the recording. If you're listening via the phone, you will notice a small time delay between the audio and the screen. This is normal, so don't be concerned. Also, our presenter may answer questions during her presentation, so you can type questions for her at any time. She will answer most of the questions at the end of her presentation. Again, type your questions in the chat box and press the Enter key on your computer. Can I suggest that you don't leave your questions to the last minute, as we will aim to finish no later than 8 p.m. Australian Eastern Standard Time. Questions will only be answered during the webinar, so again, this is a good reason to not leave your questions to the last minute. I'd also be very grateful if all participants could take a moment to respond to our feedback survey, which will come on your screen at the end of tonight's presentation. Our presenter for this evening is Dr. Emma Guymer. Emma is a rheumatologist with a professional interest in general rheumatology and fibromyalgia. She is head of the Fibromyalgia Clinic at Monash Medical Centre in Clayton, Melbourne, and has been involved in rheumatology and fibromyalgia clinical care and research for the past 18 years, both in Washington, DC, USA, and in Melbourne. She is particularly interested in the interaction between psychology and pain. We are extremely grateful to Emma for presenting this evening's webinar, and without further ado, I'll hand proceedings over to her. Thanks very much, Emma.
Right, thanks so much, Jen. Thank you, everybody, for taking time on your Wednesday night to listen, and hopefully we can talk through lots of things about fibromyalgia, which is a very intriguing, complex, and sometimes not overly well understood condition. So what we might discuss today or this evening is what is fibromyalgia and how do we diagnose it, how it associates with other illness, why it develops, how people with fibromyalgia are affected, and how the clinical features of fibromyalgia are managed. Really happy to take questions. I think just with the logistics of me looking at the screen as well as the slides, I may well leave most of them to the end, but please put them in as you think of them, otherwise you might not remember them later. So fibromyalgia is a syndrome of chronic widespread musculoskeletal pain and tenderness. It's what we call a centralized pain syndrome or a central sensitivity syndrome, and we'll talk about these terms in a minute. But it affects, on a very conservative estimate, about 4% of pretty much all the populations it's been looked at in. Although at least 10% of most populations do report chronic musculoskeletal pain. It does occur more often in women than men, but there's not such a huge discrepancy as we originally thought, and more and more men are having fibromyalgia and similar syndromes diagnosed. It occurs alone or with other chronic illness, which is quite an important thing to recognise, because sometimes clinical features that people are experiencing are not necessarily due to their initial diagnosis. Fibromyalgia clinical features include chronic widespread musculoskeletal pain. The chronic means it's been present for more than 3 months. It has most people have other variable levels of central sensitivity symptoms. So symptoms that suggests someone has increased central sensitivity. And once again, we'll talk about that term in a minute. But pretty much everyone with fibromyalgia has fatigue. They have stiffness in their muscles. They have poor quality, unrefreshing sleep. Cognitive disturbance, which means basically problems with thinking, and it often is memory and concentration that it affects the most. Emotional distress, tingling, pins and needles in odd places, hands, feet, elsewhere, and autonomic dysfunction, which refers to lots of different symptoms that people can experience, perhaps palpitations or dizziness when they stand quickly, or they have problems with their heart rate variability when they exercise, and these are quite common features. And there are a whole lot of associated conditions. So depression and anxiety are seen often, but not certainly in everybody. Headache is another one that a lot of people experience. Irritable bowel and irritable bladder. Interstitial cystitis is something that's often linked, or fibromyalgia is often seen with interstitial cystitis rather. Chronic sinus pain, temporomandibular joint disorders, multiple chemical sensitivities, so that high levels of being sensitive to lots of different environmental chemicals. You feel sick when you walk down the detergent aisle of the supermarket, or petrol and paint and perfume make you feel unwell. Quite a widespread array of different chemicals can be involved. Long-standing pelvic pain, vulvodynia, which is pain around the genital region in women. Restless leg syndrome in bed at night is also found at a higher prevalence in people with fibromyalgia. So the best way, I think, to think about this is there are a core set of clinical features that many people with fibromyalgia have, that generally form the core of the diagnostic, I guess, the sort of the features that bring it to the attention of healthcare professionals when we're thinking about diagnosing it. And then we've got all these other ones around the periphery. And everybody has their own particular personal, I guess, combination of all of these things. So one person may have the widespread musculoskeletal pain, high levels of fatigue, poor memory and concentration, poor sleep, as well as headaches, irritable bowel and restless legs. And this person has the clinical features of fibromyalgia. Someone else over here has these same features here and some of these other ones. They still have the clinical features of fibromyalgia. Someone else may have these ones here and temporomandibular joint disorder. They also have fibromyalgia, even though they don't have any of these other things. So it's something that overlaps in many different ways. And central sensitivity syndromes include things like irritable bowel syndrome and restless legs is linked to it, but chronic fatigue syndrome, all of these similar types of conditions, they're all the same thing. They just have different clinical expressions, if you like. And fibromyalgia is the one where there's pain as a predominant feature, whereas something like chronic fatigue syndrome has predominantly fatigue as a predominant syndrome. Irritable bowel clearly has the irritable bowel symptoms. All these other ones, chronic pelvic pain or restless legs, or and the autonomic problems can be most predominant, something like POTS syndrome or orthostatic tachycardia. These ones are all, perhaps the most prominent feature, but they can have some of these other things as well. All of these clinical things are under the same umbrella of what we call these central sensitivity syndromes. It's just that if there's pain involved, then generally the label that the condition gets is fibromyalgia. Now, to illustrate this point, this person here doesn't have the widespread pain. They have fatigue, they have the poor memory and concentration, disturbed sleep and autonomic problems. So they probably may well, depending on how bothersome each of these things in, what is the most prominent feature, may well end up with a diagnosis of chronic fatigue syndrome. It's still the same overlying central sensitivity condition. This person over here has the irritable bowel with these features as well. So this is where people get different clinical diagnoses, but it's all this central sensitivity syndrome, this increased central sensitivity syndrome that we're dealing with. So why does it develop? We feel that we know that people are genetically susceptible. We know that first-degree relatives of people with fibromyalgia, first-degree relatives of people with fibromyalgia are also more likely to have fibromyalgia themselves, or at least chronic musculoskeletal pain. And we think about 50% of the risk of developing fibromyalgia and related conditions is related to genetic influence. Now, there are many, many, many different genetic polymorphisms that have been discovered to be associated with these conditions, particularly fibromyalgia. Most of these are involved in the pain pathways, central pain pathways, and the function of neurotransmitters in these pathways. Neurotransmitters are the chemicals that carry the messages in the central nervous system. And so we have identified many, many, many genes, but there's not one single gene that predisposes you to fibromyalgia. Someone generally has a genetically susceptible background, and then they often come across a trigger that is either a physical or a psychological stressor. And by that I mean that there's significant stress on person as an organism, whether it's physical or physiological stress or psychological stress, that sets up these pathways, if you like, for these physical and clinical features to develop. So this can be an illness, an acute or chronic illness, maybe someone who has perhaps a chronic pain condition that's painful, like arthritis, rheumatoid arthritis, lupus. We often see high levels of fibromyalgia, and up 25 to up to 40%, depending on which study you look at. People with rheumatoid or lupus have concomitant fibromyalgia, but other illnesses too: diabetes, thyroid disease, even chronic heart failure. Trauma is another one that's often a trigger stressor, and it can be a combination. Usually, trauma involves a combination of mental and physical stress, because it's obviously an awful thing to happen to you. So you have that psychological component as well. Some people develop it in the setting of pure psychological stress, and there are people who can't identify anything. So the best way, I think, to think about it is that every human exists at any point in time on a scale of how sensitive they are to their external environment, how sensitive they are to the world around them. Down here is low sensitivity, and up here is very highly sensitive to their external environment, and it's up this far end of the scale that we call fibromyalgia. So fibromyalgia is not a disease with a cure. It is a state of how the central nervous system is functioning, which results in the way it processes sensory input from your surroundings. And if it processes them in such a way that you're very sensitive to your external surroundings, then that's what we call fibromyalgia, or increased central sensitivity, if you like. So central being the central nervous system. It's sensitive to sensory input. So up here is what we call fibromyalgia. And we are born, as humans, we're born with a sort of a genetic set point, if you like, a starting point somewhere on this scale. And this can be, this is obviously influenced by genetics. So if you have certain ones of those genes that predispose you to fibromyalgia, maybe your starting point's up here somewhere. And if you don't have many of those, maybe your starting point's down here. Also is influenced by previous experiences and how you've been able to cope with the physical and psychological stress of previous experiences. And so sort of early experiences, particularly childhood experiences, sometimes we haven't developed adequate coping mechanisms and things for those. And so they sometimes influence this situation a lot. And then you slide up this scale whenever there's an increase in the activity of the stress systems in the brain. So when you're under stress, physical or psychological stress, certain hormones and chemicals are released in the brain, and it means that you slide up this scale towards being more sensitive to your surrounding environment. And then after the stress has settled down, you slide back down to where you were. and it depends on the severity and your response to that chronic stress. So you can slide all the way up here, and if you're responding in a way where there's such a large amount of stress, or you're unable to control it, or for some other reason you're not able to reset the system, if you like, reset that fight or flight stress system, and you stay up in this zone where you're extra sensitive for a long time, and that's what we call fibromyalgia. It results in the fact that you have increased sensitivity to everything. It's not just touch and pressure. Yes, it's pain, so things that ordinarily wouldn't be painful are experienced as painful, a hug or a handshake. But experiencing odd sensations, pins and needles or numbness, where there's no reason for there to be pins and needles or numbness. Tinnitus or ringing in the ears, bowel and bladder sensations are able to be felt when normally we learn to suppress those as a developing infant. We suppress it. It's not important for us to know when food is being pushed through our bowel, or when we have small bladder sensations. Obviously, if it's full and things certainly we need to be aware of things then. But until then, those minor sensations we don't need to know, but all of a sudden you might start to experience them. Dizziness, palpitations, noise, light, odours, sensitivity to chemicals, as we talked before. And as part of that sensitivity to chemicals, there's lots and lots of side effects with different medicines, which is tricky. So this is a diagram filled in by one of my patients from the clinic, and I have had permission to reproduce this and show people in talks, because I think it really is quite indicative of exactly what people experience. Lots and lots of, you can see all these different words. There's lots and lots of different sort of descriptions of things, and lots of different things happening all over someone's body. So there's thumping and pins and needles and tight and stitches and headaches and migraines and burning sensation. Oh, I've got lots of different things I've done. So things crawling under the skin, sharp pains here and stitches here and cramps and pulling and burning. It's all different, stabbing over here. It's an absolutely awful thing to experience, and it's very hard to describe this to someone, particularly if you're at the doctor and they say, well, what's the pain like? Well, over here on my left shoulder, it's like this, and then I get this burning thing down the middle of my thighs, and then I have this other thing over here, and it's really, really difficult to explain. But all of these different things are because that volume dial is turned up on the sensory system so much. So how is it diagnosed? There's no diagnostic test for fibromyalgia per se. There's not a blood test. There are certainly abnormalities in lots of different chemicals that we see in research situations, but none of these are able to be used as a test, because they're generally quite generally indicative of a disordered function in different systems, but they don't qualify as a reliable test for us. There's also other mimics and associated conditions, and so things need to be looked at and thought about pretty carefully depending on each individual clinical feature. And I think that's quite an important thing to know. There's no one-size-fits-all with fibromyalgia. People have their own personal cocktail of clinical features, but nobody's the same as anybody else. And that's, again, why it's been quite difficult for people to kind of get a handle on. The current diagnosis gold standard it's based on the American College of Rheumatology, the 2016 diagnostic criteria for fibromyalgia, and it basically depends on two aspects of the condition. So the extent of musculoskeletal pain, so it's a count of how many painful regions in the body that have occurred in the past week. Then it also takes into account this burden of other central sensitivity features, so sleep, fatigue, thinking problems, abdominal pain, headache, and depression. These are all features that in previous diagnostic criteria really hadn't been hadn't been given much weight. So I'm pleased to see that we now recognising that this is not just a pain condition, it's a central sensitivity condition, and pain is part of that. So what's happening in fibromyalgia in the brain and spinal cord? Because I keep talking about this central sensitivity. what happens in us all is this is a piece of skin, cross-section through the skin in case you were wondering. But basically what happens is when we have a sensation, so touch or pressure or whatever on the skin, the message is carried by nerves. This is a cross-section of the spinal cord to an area called the dorsal horn in the spinal cord. And the dorsal horn acts a bit like an old-fashioned telephone exchange, if you like. It receives the incoming information from the periphery, from your skin and your joints and your it works out the sort of information it is because of the type of nerve fibre it's travelling along, from the receptor that it's coming from, and it sorts out which pathway up the spinal cord it needs to send that information. So if it's pain information, it gets sent up pain pathways to the pain areas in the brain. But if it's light touch, it gets sent up the pathways that are going to deal with light touch. If it's a joint position or posture, it gets sent up the pathways that are going to the parts of the brain that are going to deal with posture. If it's temperature change and so forth. So there's lots of different pathways up the spinal cord into the brain to the different areas in the brain that are going to deal with all these different types of sensation. Now, one of the things going wrong in fibromyalgia is that a situation occurs called central sensitization, where this dorsal horn, for several reasons, but this dorsal horn starts sending all the information it receives up the pain pathways so that the information goes to all the pain system, and so you experience it as pain. So even if it is just light touch or posture and joint position sense or temperature or whatever it is, because it's being sent up that pain pathway, it's going to the pain areas, you experience it as painful. Now this is a normal, natural protective phenomenon. This is like when you hammer your thumb for bang your nail into the wall, you hammer your thumb by accident, and for the next little while afterwards, that whole thumb area is so sensitive you can't even blow on it without causing pain. That's what it's supposed to be about. But in fibromyalgia, it gets turned on either inappropriately or it stays on longer than it should, and so you have all this information going up to the pain centres. Next is that you have these pain centres start interacting with each other, and you start having interactions with other parts of the brain that deal with processing of how we think, our psychology, our stress levels and other things start influencing how we experience these things as well. And they can modify. If you're people who can be hypnotized into or relaxed into a state where they feel much less pain. And this is where this interaction takes place up here. So up in the brain, there's this amplification of pain processing. There's a spread of cerebral activation. There's more widespread brain region activation. There's greater connectivity between different brain networks that are associated with pain perception and cognition. And again, this is where the influence of the stress activated processes occurs. And then coming back down this way is sort of the natural pain shut-off mechanism, if you like, where messages travel from the brainstem back down to the dorsal horn and says, okay, enough. We've had enough time. Let's settle all of this down. It's like some people have termed it the pain break. And these messages, how do I go back here? These messages here are carried by some of those chemicals that are genetically lower in some people with fibromyalgia. So this is not functioning as well as it should in turning this whole system off. So not only is the whole thing turned off, but you're sort of not able to turn it off. Turned on, but you're not able to turn it off properly. So I've put this in, this is 2002, very old, but what I still love about it is one of the first studies that showed us actual changes in the brain in people with fibromyalgia. So this was Rick Gracely and co in Washington, looked at people, so these looked at people who had fibromyalgia and people who did not have fibromyalgia, and they squashed their thumbs, basically, while they were in an MRI scanner. And so if you can see across here, this is how intensely their thumbnail was being pushed down upon. So up here, much higher than down here. And this is how, up on this scale, is how painful it was for people. And you can see that these people, the triangles of the fibromyalgia people, felt the same level of pain as the people without fibromyalgia, but at much lower thresholds of pressure on their thumbnail. So same pain, but much less physical reason to feel it. And this is the same group of patients, and you can see that the patients with fibromyalgia had the red dots. Their brains were lighting up in the same places as the patients without fibromyalgia when the thumb pressure was much higher, so that when the people in the yellow who did not have fibromyalgia had pain, these are the areas they lit up. And the fibromyalgia patients lit up in those same areas, but at a much lower strength. So this was proof for the first time pretty much that actual brain changes were the reason why people were experiencing pain. People weren't making it up. People weren't malingering or anything else. This is the real deal. So there are other changes going on in the brain too. There's disruption of stage 4 non-REM sleep. So that means that you're not able to get down into deep layers of restorative, refreshing sleep. There's these little alpha-delta spikes that keep you up in this lighter layer of sleep. Stress responses, so the sympathetic nervous system and the hypothalamic pituitary axis are the main ways that humans respond to stress, and they are both abnormally activated in fibromyalgia. There's also other things that are triggered by ongoing stress responses. There's small amounts of central neuroinflammation. There's stress in the gut results in increased permeability and some inflammatory mediator release. There's lots and lots of different things going on all at once. And again, we talked about the autonomic function. There's also peripheral changes, so things that happen out not in the central nervous system, but out around the peripheral nerves and in the peripheral blood vessels and things in the skin. So there's increased blood flow and blood vessel permeability in the skin due to small nerve fiber microinflammation, and you see this wheel and flare response. That's what we call dermatographia, but also that livedo type pattern, that chicken wire sort of pattern on people's skin. Some people get some Raynaud's phenomenon, peripheral swelling. You go to the doctor, say, my hands are swollen, I can't fit my rings on. The doctor looks at your hands, oh, they look all right to me. It's that mild peripheral swelling. And there's also, in some people, about 50% of people, perhaps some small fibre abnormalities in small nerve fibre abnormalities in the skin. So things to remember at this stage is that fibromyalgia has fluctuating symptoms due to whether there's physical or psychological stress. So if you have a cold or a flu, you feel worse. If you have an argument with someone, you feel worse. Even good stress, you go on a nice holiday, but it's jet lag and you still feel worse. It's not dangerous or degenerative, despite making life miserable. The clinical features can improve over time, and treatment has varied effects in different people, and that's something quite tricky to deal with. So the management of fibromyalgia really does depend on a multidisciplinary team. Best coordinated by the GP, but there need to be lots and lots of people in this network. Psychologists, exercise physiologists, physiotherapists, lots of other people, depending on who and what you want to include in that, myotherapists, naturopaths, acupuncturists, whoever, the more the merrier, as long as they're helpful. And medical specialists, I think rightly, are down the bottom. They really don't have as much role to play as everybody else. The important thing about fibromyalgia is that management is that it needs to be multidisciplinary. We need to have everyone on board. We need to attack this from lots of different angles because it's quite a complex thing in the way that it occurs. And so we need to really have multiple levels and layers, if you like, of intervention. But the first and the most essential thing is education. And educating yourself as well as support people and anyone around is so important. Just talking about what it means, how it occurs, how big a problem it might or might not be, the ways that we manage it, and also realising that it's not something, as I said, it's not a disease with a cure. It's the current state of how your central nervous system is functioning. You always have the tendency over life to slide up that scale, if you like, back into the fibromyalgia zone, but you know, if you are able to develop a toolkit and I guess a way that you can manage these clinical features, and it's quite empowering, and you're able to get on top of things, and you know, well, I haven't been doing this, and I haven't been doing that, and it makes a big difference. Then that's hugely powerful. Really important to talk about it to other people. You know, people look great, just that they feel rubbish. And I think that's very important to explain. And if someone's important in your life, help them be educated, because it's too hard just doing this without people who understand. Psychological strategies are essential in fibromyalgia. We know that stress response is the main big driver in many ways. And so to control how you respond to stress is pretty much the most powerful thing you can do to control it and use it as your toolkit. So I tell everybody, daily mindfulness, meditation, or other pain management therapies, whatever you do, find a way to control stress levels. Now, if you're someone who finds meditation, relaxation in art or prayer or music or swimming or whatever it is, just try and be quite religious about that and do it twice a day. Even those small apps, Smiling Mind, Headspace, there's a billion of them on your phone. Twice a day, 2 minutes breathing exercises, essential. Sleep hygiene is also important. The standard things that they talk about that, and I'm sure that you're aware of all that, but same bedtime every night, no caffeine, chocolate, or anything in the afternoons. Oh, come back. All of those things. Cognitive behavior therapy is the psychological therapy with the most amount of evidence scientifically behind it, but there are other strategies as well, operant behavior therapy and all sorts of other things. But this is the one that has most of the evidence so far. It's run by therapists and psychologists, best with someone who's trained to do this for pain. It needs to be a tailored program for pain. Don't go along to a class that does smoking and fear of heights and everything else. That's not going weight loss. It's not going to be what you need. But it helps with teaching you basic things such as relaxation, pacing of activities, goal setting, coping strategy, all those things that are absolutely essential. The other thing that I get on my bandbox about a soapbox about in fibromyalgia is gentle aerobic level exercise. And I will say it for the 47,000th time this week, nobody gets better unless they do the exercise. They do not get better. It doesn't. They just can't improve unless you start incorporating this in your life. Now, having said that, the aim is 20 minutes 3 to 5 times a week. Now, for many people, if you go and try and do 20 minutes of walking, you'll feel like you've been hit by a bus and you won't get out of bed for a week. You feel much worse. That's not helpful to anybody. You have to start gently and slowly, maybe with a minute of slow walking in one direction and a minute back. I mean, you feel a bit silly doing only 2 minutes of walking, but I'd rather you do 2 minutes of walking every day per week than 15 minutes once a week. And you can build it up slowly over months and months and months till you get to 20 minutes of activity, whatever that is, at slightly faster pace where your breathing rate and your heart rate is raised. I love warm pool exercises. They take the ouch out of the muscles, they take the weight off the joints, allow you to move freely, and you don't actually have to do very much to raise your heart rate in a pool. You can just hop in there and wallow, move your arms around or bicycle your legs, and that raises your heart rate. Once you have a higher exercise tolerance, then things such as resistance training and things can play more of a part. Other ways that we manage fibromyalgia, and I said the more the merrier, the more ways that we can approach this, the better. Massage, many people like massage, some people don't. Acupuncture, yoga, all of those things are helpful to some people some of the time. Tai Chi, there's some lovely evidence showing benefits of Tai Chi. What that red dot is. Another one that's being looked at the moment is repetitive transcranial magnetic stimulation, or theta, the newer version of that is theta burst stimulation. And there's a current, there's some overseas and some local pilot data looking at this, and there's an ongoing study through the Alfred MapRC in Melbourne, where there's some theta burst stimulation being trialled. So that's all good news, and maybe something else that we can have in our armamentarium. Other things that have to be looked at. You're not going to feel any better. Come back. Not going to feel any better if there are other peripheral pain generators, if there's lots of osteoarthritis, or there's major depression, or obstructive sleep apnea, or inflammatory problems. All of these things need to be addressed because these are physical stressors and they will be making fibromyalgia worse. Other symptoms need to be thought about, and lots of other things that cause cause psychological stress. These all need to be addressed if you're going to clear some space and really have an impact on how the symptoms are affecting you. Medication helps some people some of the time. It really doesn't help that much, and it's really not very predictable either as to who's going to benefit from what. The standard rule is 30-50, the 30-50 rule. So 30% of people feel 50% better, 50% of people feel 30% better with the current medicines, and there's really not much better than that. But it never works very well, ever, unless you're doing the exercise and controlling stress. Simple pain relief, Panadols, those sorts of things, anti-inflammatory agents help some people some of the time. Some people go for, really do feel that having a couple of Panadols 2-3 times a day does do things for them, but many people don't. And I'll talk about opioids in the next level. So Panadol's a little bit atypical, and there's some, as is Tramadol, and there's some reasons why that they have a little bit more benefit than normal opioids, but which we'll talk about. But in general, these things aren't overly helpful unless there's another reason. If there's lots of osteoarthritis, which is continuing to trigger the fibromyalgia, then having some baseline general analgesia is helpful, but they don't help the underlying pathophysiological pathways of fibromyalgia. Opioids or narcotics, so these are not recommended in the use of fibromyalgia. There is no current evidence to support their use. In fact, there's some evidence of an overactivity of the endogenous, which means the natural opioid system that is occurring in our own brain and spinal cord. And it seems to be that there is some evidence that this is hyperactive in people with fibromyalgia. And if you give people opioids, it can actually make the situation worse. So avoid them at all costs. And on top of all of this are the safety concerns regarding, they're really quite addictive. People become quite tolerant, and we end up I think Australia is currently delving into the opioid crisis as swept through the United States and elsewhere. On the flip side of this is low-dose naltrexone, which is actually the opposite of opioid, if you like. We use it to reverse heroin overdoses in a slightly different way, but so it's an anti-opioid, if you like. So it cannot at all be used together with an opioid medicine because that can induce withdrawal. But there's some small amounts of evidence that very small doses at night can help some people. It's not available in Australia, marketed for fibromyalgia, but with a compounding pharmacist, it can be made up. It might help pain in some people, but the evidence is still pretty minimal at this stage, but there are certainly some people who feel better on it. The other medicines include low-dose amitriptyline, or NDEP, which some of you may have come across. It's marketed as an antidepressant here in Australia. However, the doses that you use for fibromyalgia are much lower. So 5 to 10 milligrams is where I'd start, and I really wouldn't go above 20 to 25 milligrams. Otherwise, then that becomes antidepressant doses. If you need it for antidepressants, no problem. But for fibromyalgia, you don't need it that high. If it's not working, it's not working. Throw it in the bin. This is not a life-threatening condition. Nobody needs medication. If they're not helping or they're making you feel sick, throw them in the bin. Milnacipran, or Joncia, is the only medicine marketed for use in fibromyalgia in Australia. However, it's not on PBS, so it's expensive. And it, again, is under this umbrella of the serotonin noradrenaline reuptake inhibitors, as is Cymbalta. And basically what they do is they improve this downward pain control coming from the brainstem, basically. They improve the levels of serotonin and noradrenaline, which are those neurotransmitters that are genetically lower in some people with fibromyalgia. The fact that many of them, and Cymbalta is another one, that are marketed as antidepressants, really just means that they raise levels of serotonin and noradrenaline right throughout the brain, including in the areas that deal with depression, which is why they act as antidepressants as well. However, Johnsy is the only one marketed for the use in fibromyalgia in this country. Another way of managing fibromyalgia with medication is to use medicines that reduce the excitability, so reduce this increase in messages into the pain system and slow down the volume or reduce the volume of that pain system sort of excitation, if you like, using medicines such as Lyrica or Neurontin. Cannabinoids, I knew that I'd have lots of questions about them, so this is the current take on them as far as I can, as in my opinion, that we have no current unbiased evidence that is convincing enough to support their use in fibromyalgia. They're not tolerated very well. There's high numbers of dropouts in the studies. They're only short-term in duration. There's not really a significant difference seen in pain in these studies, and I just don't think we need much more research before we can recommend their use in fibromyalgia. And at this stage, I don't think it's a good idea. And then there are many other things that people find helpful: magnesium supplements, melatonin, other things, and there's a whole long list of things that some people find helpful, but some people don't, and it is very hit and miss. So once again, managing all these coexisting conditions is very important, otherwise that can keep stirring up their fibromyalgia. And as a summary, I need you to remember that it is a common and debilitating condition, but it is not dangerous or damaging, and it results from a disordered processing of the sensory information in the central nervous system. There are fluctuating symptoms which are worsened in situations of physical or psychological stress. The best way to manage this is with a proactive, multidisciplinary approach to management, where you develop your own personal toolkit about what works for you and you are in control of managing it. No one therapy works well on its own, and combined therapies can be very effective. So I'll leave you here. I've just put this up, and I know you're going to get a copy of these slides, but these are things that I find useful to give to patients. There's lots of different websites and places to go to explore on that. And thank you. And now I'll look at some questions. Okay.
Yeah, Emma, there's certainly, thanks very much for a very comprehensive presentation. We've certainly got quite a few questions here, so let's see if we can zip through some of them. One of the first questions was any connection between bacterial infections, such as chronic gut infection, and fibromyalgia?
Yeah, so connections between, the question was the connection between bacterial infections and fibromyalgia. Chronic gut infection would be included in all of that. Look, any infection, particularly if they're long-standing, will act as a physiological stressor. And so in that situation, people are more prone to develop fibromyalgia, just simply because it's putting your body, your organism under stress.
A question when you had up your earlier slide about all the different sort of possible features and how you might have different combinations of features that might lead to a diagnosis.
Yes.
A question came about, does it mean that all the other features might need to be treated separately?
No, we manage all of these conditions in general the same way. There are slight differences depending on what is the most prominent feature. So the gastroenterologist may well manage the bowel features of irritable bowel in a certain way, whereas people, if you're seeing someone for pain, we may well manage the pain features in a certain way, and the fatigue, the sleep physicians may well look at other things. So Depending on the specific feature, certain attention might be given to that, but in general, all of them need control of stress, all of them need gentle exercise, and many of them will respond to the same sorts of medicines, even if they're slightly different.
You mentioned in one of your later slides about the naltrexone, so hopefully the person who posed that question has had a satisfactory answer. Next question, have you seen glandular fever as a trigger?
Once again, yes. Again, that's a chronic infection, so yes, we do see that as a trigger.
And a question was with regards to how does stress actually cause fibro or the central sensitivity syndrome from the point of view, I suppose it's that sliding scale that you explained earlier.
Yeah, look, it's what it does, and I didn't get all into the nuts and bolts of that because we'd need another 3 hours of discussion. But essentially, when your stress systems in your brain are triggered by stress, they release certain chemicals and hormones, which then flow throughout the central nervous system, activating all of these other features. Now, it may be temporary if you're able to control that stress activation pretty quickly if you're someone who's got well developed sort of stress handling techniques, and you can get on top of it first, then you might just get a bit of a bad headache and feel a bit average and go to bed for the evening and feel a bit better in the morning. But if this is ongoing stress hormone release for a long period of time and you remain in that fight or flight mode, then yes, you can feel very sick.
Next question is asking if you do not have insomnia. A person's been told that they then don't have fibromyalgia, even though they suffer from the 3 other main features that were mentioned. So even though they don't have a refreshing sleep, might they still have fibromyalgia?
Yes, so that is exactly what happens. Even some people will sleep for 8 hours and still wake up and feel completely unrefreshed, feel like they haven't been asleep for a second. Other people will have very broken sleep and not feel refreshed. It's really variable, like the rest of this condition, such a variable situation. So I do advise people, if they haven't had a proper sleep assessment, to go along and see someone about that. Whether they have obstructive sleep apnea or, movement disorders or other things that can be interfering with their sleep. It's certainly very important that everyone has that assessed. But, and you've got to be clear about your definition of insomnia too, because once again, you can sleep but not feel refreshed. Is that insomnia? You'd have to be very clear about exactly what you're experiencing before you feel like this definition doesn't fit you, I suppose.
And if someone's been diagnosed with fibromyalgia, should they be seeing a rheumatologist? This person has seen a urologist, but hasn't had much help with managing the condition.
Look, to be honest, GPs are terrific at this in most situations. They're onto it, and they're really good at covering all those bases we were talking about before. You may well need some help from an exercise physiologist or a physio or someone for nutrition or whatever. Certainly a psychologist. You don't need a rheumatologist. We have a role if there's some question about whether this is perhaps an inflammatory arthritis or some other reason why there is musculoskeletal pain. But in general, if the diagnosis has been made, GPs are generally pretty good at coordinating all of it.
And Emma, have you had any experience with fibromyalgia and reflexology?
Some people find it helpful and some people don't. And I think for a lot of these therapies, it's a bit of a suck it and see. If you feel better, great. If you don't, remember that most of these types of things are expensive. And once again, if it's not providing benefit, then don't keep going. I guess as long as it's not a dangerous alternative therapy, I've heard some dreadful stories about people drinking their own urine or having coffee enemas and all sorts of things like that. That's dangerous. Don't go near it. But if it's something that you find helpful, keep doing it. And if not, do something else.
Would that also apply to the next question in relation to the use of a TENS machine, whether that would help fibromyalgia pain?
Yeah, look, some people find it helpful and some people don't. And once again, just please please try it. All of these things are useful for some different people, and it may be that there might be some other aspects of, some osteoarthritis in the spine or something that's sort of making the fibromyalgia sort of worse. And so those sorts of strategies may help in that way.
And question, has much research been done regarding a link between chronic fatigue syndrome? New research that shows that chronic fatigue has a physical cause and that fibromyalgia may be a consequence of the physical problem that causes chronic fatigue. It is that fibromyalgia is actually a symptom of chronic fatigue.
Okay. Look, the way that I think of it is that they are all different expressions of the same underlying process, if you like. And so I don't think that one causes the other or vice versa. But if people have this sort of system up and going, then they may well experience initially fatigue and then develop the pain later, or pain first and fatigue later. It's not. It's all just an expression of the same process occurring in people, but different things come and go at different times.
And Emma, the role of any specific vitamins or minerals that might help?
Look, everybody is different. Once again, it's not something that I can recommend particularly. There's no data that's ever come up in large studies that's resulted in a definite recommendation in this way. I think if you have vitamin deficiencies, clearly they need to be replaced. Some people do find magnesium supplements helpful for the muscle cramps. But I don't think high levels of vitamins in any particular way have been shown to be helpful. It's really important to have just a very balanced diet and make sure that nutritionally you're as good as you can be.
And someone just seeking clarification, saying it sounds like you're saying fibromyalgia is all about stress. Is that right?
It's very linked to it. It's very intertwined. These are physical changes occurring in the brain and spinal cord and in the periphery. They are definite physical changes. However, stress seems to be, physical and psychological stress seem to be a large driver of this on the background of those genetic predispositions. So it's really intertwined. These are real physical things that are happening, but it does tend to be that those stress drivers tend to trigger it off and make it worse. And that's the best way we can talk about it for the minute. But they're very physical changes. This is not an expression of psychology or anything else in general, other than the stress will, I guess, result in these changes. Having said that, fibromyalgia can occur from peripheral inputs as well. If someone has a peripheral injury or terrible osteoarthritis or something like that, that can be the main driver. But and so that's sort of a reverse situation, and you can have lots of pain sensitization around that. But generally, you don't get those high levels of widespread sensitization, even in those situations, if there's good control of stress.
Emma, do you know of anyone who's studied the lactic acid levels in muscle as a source and cause of pain?
Look, I think it's been looked at, and I do remember reading papers about this. I think that the numbers in these studies are probably not huge, and there's no evidence that there's any muscle pathology per se in fibromyalgia. Now, we know that buildup of lactic acid causes pain in muscles, absolutely. But in fibromyalgia in general, there's no evidence of it being abnormal in everybody, no.
And any long-term complications of being on Cymbalta?
Long-term complications. Look, Cymbalta, depends on why it's being used and how you respond to it. There's no long-term permanent damage in general, but there's a whole lot of things that can be side effects and adverse effects, as there can be with any drug. People with fibromyalgia can experience those at a higher rate. Things that are serious, it can worsen depression, paradoxically, which is something to watch out for. That's often early on. It's something that you have to come off slowly if you have been taking it for a long time, but in general, there's no permanent damage that we're aware of that it can cause. If that was the question.
Mhm. And Andrew, there's a question about, is it the same as CBD oil, but I'm not quite sure to what you're referring there. Patricia asked, are conditions like psoriasis and rosacea linked to fibromyalgia?
Look, they can be in that they're chronic inflammatory conditions, and so anyone with a chronic inflammatory condition, because they have that physiological stressor, it can result in an increased likelihood of developing fibromyalgia. And we certainly know that the more medical conditions you have, the higher your likelihood of developing fibromyalgia is.
Someone asked, is there a fibro clinic in Sydney?
Lots and lots of people that see fibro patients privately. I don't know that there's a specific fibro clinic in Sydney, but I may well be incredibly wrong. I don't know.
Maybe we can see if we can find out and let people know after when we send out the follow-up resources.
Sure.
Question, you and other rheumatologists at the Fibro Clinic at Monash still taking new patients?
Yes, of course we are. We do have a waiting list. We're working hard on bringing that down, and we've got we're slowly trying to work on strategies for that. But absolutely, we need a GP referral, and we run regular seminars, a bit like this one, out at Monash. While you're on the waiting list, you get invited along to those, and we see you as soon as we can.
And Emma, are there any recommended exercise guidelines currently for people who, may have fibromyalgia?
Look, gentle exercise guidelines, yes. The thing is, the best thing is to find something that suits you, I guess. You can look, there's lots of management guidelines published by the Canadian rheumatology associations and the American and the European ones, but they're generally not patient directed. I think the best thing to do is to make sure you do something gentle and low impact and raise your heart rate slowly. And if you're having difficulties kind of getting your head around that, someone like an exercise physiologist or a physio are the best people to see who can guide you through that.
A bit of a general question, what helps with sleep? I suppose there's lots of different possible ideas and remedies there.
Yeah, look, there are lots of things, but in general, improving the whole thing, the controlling stress and the gentle exercise really do help with the sleep along with everything else. That sleep hygiene, that whole list of things, and you can just look at that online. There's a whole raft of things there with the sleep. But once again, anyone with sleep problems, I do encourage you to go and just have all of that checked out and see if there's anything else that can be added.
It's probably a bit of a difficult question for you to answer, Emma. Why don't GPs know more about fibromyalgia? You've obviously come across a lot of GPs that you commented before are actually pretty good at managing people with fibromyalgia.
Yeah, no, some great GPs who are terrific at managing fibromyalgia. I think we've been the education side of it's been a little bit sort of slow to catch up in little ways. I mean, most newer graduates coming out are really pretty good about understanding fibromyalgia and knowing how to manage it. And I think there are people out there who are less educated. It's also incredibly hard in a 7-minute GP consultation to really address a lot of this. So sometimes booking for a longer GP appointment is helpful too.
And what about infrared saunas? Might they help?
I don't know. Let me know. It's one of those things that I've not seen any evidence about.
Is high blood pressure a symptom of fibromyalgia?
So fibromyalgia won't really change. It won't give you high blood pressure. It can make you feel more unwell if you are symptomatic with high blood pressure, but it won't cause it.
And question: Can you ever get rid of fibromyalgia, or is it mainly a matter of managing it?
Yeah, look, as I said, it's partly your genetic makeup, and it's partly how you are able to control it with your personal little proactive self-managing toolkit, so that your exercise and your stress reduction and whether you have some medicines in there or not. And many people will say, oh, the symptoms completely went away, but then I had another big, something go wrong, and they've come back again. You just have to know what helps and get back on your bandwagon and get back into your gentle exercise and controlling your stress, and you generally reduce those symptoms. So it's just the sense of sliding up and down that scale, and staying on the lower side of that threshold line, if you like, on that scale picture is probably the best way to visualize it. So you always have the tendency to develop the features when you're under the pump, or you're sick, you get a cold or a flu or jet lag or something. Or an operation, anesthetics can do it, but if you know what you need to do to get better, you can slide yourself back down below the line again, and that's the best way to think of it.
Look, we're going to have to stop there. I'm sorry that there are a few more questions, but we've run out of time this evening, and I think, Emma, you've done a great job of actually addressing quite a few questions already. So, look, I'm sorry to those whose questions may not have the opportunity to be answered this evening. But Emma, I'd like to thank you very sincerely for your great presentation tonight and your willingness to actually answer so many questions in a fairly short space of time. So thanks, Emma. Thanks everyone for joining the webinar this evening. The exit survey is now on your screens. I'd be very grateful if you could take a moment to fill in the exit survey, and don't forget there's lots of information on the Musculoskeletal Australia website as well, and we'll certainly be in touch with our follow-up resources after this evening's webinar. So on that note to everyone, I wish you a good evening and good night.
Good night. Thanks very much.